I'm not that short. I'm not that tall either. And now, let's see what we've got here. Okay, how's that? Is that good? Okay. And just to prove to you that I'm not as young as I used to be, I do need my eyeglasses now to see what's going on. So thank you so much for having me here today. It's always pleasant to come into the room and see familiar faces and friendly faces. And that's this is one of the true joys of what I get to do. I come to you on the backside of traveling for about the last 20 days. Winnipeg, Boston, Ottawa. No, let me correct that. Ottawa, Winnipeg, Boston, Ottawa, Montreal, and back home. And I share that with you to say that all of this travel has really been about you guys. And it's been an advocacy of Parkinson's disease and research in Parkinson's disease in terms of cognition and language and communication disorders. And that's incredibly encouraging to me. 10 years ago, that would not have happened. And a lot of the talks that I had the pleasure of giving were given to professional groups, so speech-language pathologists, physiotherapists, occupational therapists, physicians, and nurses, about the speech and language and cognition and communication changes in Parkinson's disease. And 10 years ago, we weren't having that conversation. We were talking about speech challenges only. We weren't talking about cognition or language challenges. And certainly physicians and my own colleagues as speech pathologists didn't believe me when I kept telling them that these challenges were there. I believed because you, people like you, told me that this was a problem for them. And I started working on those problems. But my colleagues really didn't. So to be asked to give a full day talk at Speech-Language Pathology Association meetings across this country because people are concerned and interested in how to help you. How to help people with Parkinson's disease now communicate better, work on their speech challenges. We have new technologies coming down the pipeline every day to help with this, so there's hope and encouragement, and that message is strong. And so this year was really one of those great years where I thought, wow, people are getting the message, they're understanding, and they're keen, and they're excited about helping folks to improve their quality of life. So this was a good year. So it's a right and appropriate to finish my talk here at home, to be back home again in a way. Although those of you who know me know I'm from Tennessee, and so Ontario is kind of my adopted home, which means if I go too fast, I'm also a storyteller, which is why you get the storyteller at the beginning. For those of you who have known me for a little bit and seen me on the circuit, I am proud to announce with a very strong thank you that in about 6 weeks from now, I will be defended and my PhD will be finished. And I will finally be through this process that really started with the advent of many of you saying to me that I had challenges. So for those of you in the room who've been with me through that journey, this is also my chance to say thank you. No. That's almost as bad as the introduction, so don't do that. But I did want to, as I kind of travel around to groups, I do want to take that chance to say thank you, because in large part, a lot of this would not have happened without you. So today's talk is a little bit of bringing the same new and exciting information about changes in the options that we have for treating some of the speech disorders in Parkinson's disease to you guys. So I've been traveling this message to professionals, and now I'm going to bring it to you. There's two ways to solve a problem. You teach the people who actually need to implement these therapies, and then you teach people with Parkinson's disease so they know what to ask for. And so we're going to kind of deal with the bookend of that. There's a couple of things I have to always put up there. So Parkinson's disease we know about, and we know as the disease progresses, it certainly becomes much more complicated. We have this honeymoon stage in Parkinson's disease where really for the first 3 to 5 years it seems like a relatively simple condition to work with. But beyond about 5 years, we have this whole host of non-motor symptoms, or those things that aren't directly linked to the changes in walking and gait and tremor in the hands. And they include swallowing changes, changes in mood, subtle changes in thinking skills or speed of processing that can be quite mild for some individuals and can actually progress to dementia for others. We have changes in speech and language and communication, and I'll define a couple of those terms. Speech is actually the motor movements of your mouth. It's how your vocal cords and your tongue and your jaw and your teeth all help to produce speech sounds. But behind that are a whole host of other things, like the rules that we use to put words together into sentences and sentences into thoughts. And when we combine all of that, the thinking skills and memory, the motor speech aspects, and the rule-based systems for how we combine sounds and words, then we actually get this beast that's called communication, and it's all those things put together. For the longest time in Parkinson's, we've really focused predominantly on speech. We've not focused very much on communication, but that profile and that approach is certainly starting to change. And I'm quite proud of our Canadian model for being one of the first countries that's really adopted that, both in our policies and in our care statements. Bowel and bladder changes, blood pressure regulation changes, and pain. So Parkinson's disease becomes really, really complicated. And at least the cognition, speech, and language and communication challenges are what we're going to focus on today. So a little bit about the speech changes. I don't have to exactly tell many people in the audience about this because most of you are living with this, but some of the typical changes that we see in the speech of people who have Parkinson's disease are changes in loudness. So the voice volume can become quite quiet, and we can see this from the earliest stages of the disease. We can see changes in voice quality, such that the voice becomes slightly hoarse. It's not as clear, or the pitch may change, so that for women in particular, the pitch can lower, so your voice may not sound like your voice anymore. And speech sounds become a bit more imprecise, meaning that there can be challenges saying the sounds as clearly as you would like. For some people, their speech becomes slower. For others, their speech can become very fast and quick, so much so that it almost appears that they're stuttering or stumbling over their words. So those are all typical changes of what we expect in terms of Parkinson's disease, and we'll talk a little bit about what causes those changes here in a bit. There are typical changes in cognition, and cognition being kind of I know that Dr. McDonald used this term earlier, but really an overview term for thinking skills in a way. We know some of the earlier changes that happen in individuals with Parkinson's disease can include changes in focusing or shifting focus across multiple thoughts or topics, changes in planning and organizing. While memory changes can occur, they're certainly not the most typical cognitive change that we see in Parkinson's disease. Unlike Alzheimer's disease, where memory changes are salient or quite common, we actually don't see the severity of memory challenges in Parkinson's. So some of the tip of the tongue phenomenon in terms of coming up with words, but not the true memory challenges that you see in some of the other disorder groups. And what we know about the memory challenges in Parkinson's, for people who have Parkinson's, is that the information gets in, the trouble is just getting it out. And so they often respond very well to cues or learning strategies for how to get the information out. So we call this a retrieval problem, getting it out, versus an encoding problem. And the exact opposite is true in some of the dementias, like Alzheimer's disease. They can't store it in, and so then they can't get it out. People with Parkinson's typically can store it in, they just can't retrieve it out. So with a few helps from communication partners, such as reminding them of the first sound of the word, or giving them a clue as to what word, or helping them retrieve the word, or the memory concept, they can actually do quite well. So communication changes include, as I said, changes that are affected by speech and language in terms of thinking about how to put words into sentences and sentences into thoughts. But some of the communication challenges that we see in Parkinson's disease are certainly not just motor speech changes. And 20 years ago when I was trained, and I was, honestly, 20 years ago, that's when I finished my program. So 20 years ago when I was trained, the only thing we ever talked about were the speech changes in Parkinson's, actual change in voice loudness and voice quality and clarity of producing sounds. We never, ever, ever talked about it as a communication problem. But when I was in the clinic and I'd see 30 patients a day, 20 patients a day, they were all saying, it isn't just my speech. I have trouble coming up with the right word. I have trouble making my thoughts known. I have trouble listening to others because the speed of conversation goes so quickly that by the time I've processed what someone wants to say, by the time I've planned what I want to say back, the conversation has moved on without me. And because it's moved on without me, what I have to say no longer seems relevant. And so I often just sit back and become quiet, or I choose not to socialize as much as I used to. But we weren't talking about that 20 years ago. We really weren't even talking about it 10 years ago. So these are all fairly new pieces of knowledge for us in the Parkinson's community. But a couple of years ago, Nick Miller, this goes back 2008, 9-ish, Nick Miller out of the United Kingdom and his group actually asked 141 people with Parkinson's disease, how would you describe your troubles speaking? So they wanted to capture the experience, your perception of trouble speaking. Almost all of the respondents didn't list the trouble with their speech being their number one problem. It was finding words, following the pace of conversation, attending to what others were saying, remembering what they wanted to say. And then at the bottom of that list was their voice and challenges getting sounds out. And that really raised the awareness in our field at a very high level that this was more than just a speech challenge. So some of the changes that we see include trouble turn-taking, so those pauses, very long pauses as they work to process or plan what needs to be said. And then typically, language just loses some of its complexity. And I often hear folks with Parkinson's say this, I just don't sound as smart or as sophisticated as I did before I had Parkinson's. I have to choose to use simpler sentences or words that are easier for me to retrieve. So it makes them feel not so much like themselves. When I was in Ottawa a couple of weeks ago, I had a school teacher say to me, her very first sign of having Parkinson's disease was that she couldn't keep up with her students in the classroom. So she was a science teacher, a grade 9 science teacher. And she was having trouble coming up with the common words that would be in her lesson plan, and her students were having to fill in. And she'd been to 4 or 5 doctors, along with some slowness in her walking, telling them something was wrong, and they told her it was menopause. They told her it was depression. They told her that she had ALS. And she finally got to the right doctor who said, this is Parkinson's. And the gentleman that she saw is a very good colleague of mine. And he said, those changes come along with the motor changes. And he was exactly right. But even in our recent clinical knowledge, sometimes we still have trouble getting to the right spot with this information. So again, some of the other things we talked about, following pace of conversation and finding words. So there's a variety of ways that we can manage these changes. And the one that most of you are most common with are medications, right? So how many people in the room are on medication for Parkinson's disease? Yeah, most everybody, right? So how do we manage this disease? We manage it typically by giving medications. And the most common of those medications, there's a variety of medications that can be used, but the most common of those is levodopa. And what levodopa and the other medications do, in large part, different mechanisms. They work in different ways. But their job is to help optimize the residual dopamine in your brain, either by mimicking dopamine or by blocking other chemicals that disrupt the way that dopamine is used to talk between brain cells. So there's a variety of mechanisms depending on the medication that you're on, but typically we're there to optimize dopamine. So how do medications do in terms of helping us with some of these speech and language and cognition problems? Well, it's kind of mixed. As Dr. McDonald spoke earlier, the effects of medication changes on cognition can be variable depending on exactly what aspect of cognition you're looking at. On language, they can either improve some aspects and worsen others. So medications don't always help us, equivocally in terms of language challenges. And with speech changes, you'll often see an improvement right after you first start taking the medication, but that quickly goes away. So the medications that we use in Parkinson's disease really are geared towards aiding with movement and walking and reducing tremor. They're not so much aimed towards helping out with speech. So then we have surgical options. Do I have any DBS folks in the house? Anyone who's had DBS or is planning on having DBS? Oh, hi, Judith, hi. I see you, and I see your face, so I know who you are. Hello. So DBS is becoming certainly much more prominent in terms of its accessibility. So in London alone, we now have 3 surgeons who are able to do DBS. In Toronto, they have several, and so we're starting to see the availability and accessibility of this surgical procedure become more available. For those of you who don't know, it's a surgery procedure that involves putting probes down into particular regions of the brain and then putting an electrical signal into those probes to aid in stimulating or affecting, modulating the activity in certain parts of the brain in order to reduce motor symptoms and allow people with more severe cases of the disease to get by with less medication, because sometimes more medication can cause more complications such as extra movements and whatnot. But in terms of how surgery does to help speech and some of these cognition and language challenges, well, and I heard Dr. McDonald say with cognition, it's a bit of a mixed bag. Some people do actually worsen in cognition with this surgery. Typically, unilateral STN placement or subthalamic nucleus placement does a little bit better. For speech, if you stimulate the thalamus, because there's 3 different places you can put these probes, if you stimulate the thalamus, speech is always going to get worse. If you stimulate GPI, globus pallidus interns, it's always going to get worse. The best outcomes we really have for speech are the subthalamic nucleus probes that go in. And so in that case, surgery can improve speech for a lot of individuals, although certainly some worsen as well. So it as well is not our ubiquitous solution for some of the speech challenges that we have, which leaves us in this category of really behavioral therapy. So speech therapy, occupational therapy for working on aspects of cognition, as well as some of my colleagues in speech therapy. So in large part still, the management of some of these communication challenges are behavioral. They're old-fashioned therapy, hard work, learning different ways of doing things, or rebuilding skills. So one of the approaches that I take with this is a little bit different than what my colleagues take, and is a message that thankfully is starting to spread a little bit, which is the fact that communication is a much broader concept than just speech, and we need to be thinking about it from the perspective of what it's used for, which is to send and receive messages and to build relationships. And with that in mind, it becomes important that we work not only with the person who has Parkinson's, but with all of the people in their lives with whom they have meaningful communication. So when people see me at the university clinic or when I'm working with them, I never just focus on the person with Parkinson's, but I look at their partner, I look at their grandchildren, I look at their siblings, I look at the person at Tim Hortons or the church committee, whoever it is that this person has meaningful activities with, and we work with them as a whole unit. Because that's how we communicate. We don't communicate in boxes. I mean, some of us do, and I spend a lot of time alone working, and so I talk to my computer a lot, and I talk to myself a lot. But for the most part, communication is a very social activity. I don't necessarily put dogs and cats in that mix, although I know people talk to them a lot as well. But the other people in their lives we tend to work on. And we think about not only the changes in speech, the changes in language, the changes in cognition, what we call the impairment level, but we also think about what are still the strengths that you have in communicating. Do you still have a brilliant sense of humor, and how do we optimize that? We think about the environment in which you're communicating. Can we change something about that environment that makes it easier? And this often means that we're taking a multidimensional approach. And this is the message that I've been spreading around to my colleagues, and it's starting to be received. And it's a similar approach to what we've been doing with stroke for years, which is one size does not fit all. There is no such thing as a single best therapy for someone with Parkinson's disease. When it comes to managing communication challenges, and I would say movement challenges and ADL challenges, when it comes to managing this condition, it is really important that we think about the unique solution that is right for the person sitting in front of you and their family unit. There is no such thing as a best therapy. And so that's what we try to get people thinking about. So in our toolbox, so to speak, we have the medications and surgical approaches that I just got done talking to you about, but we also have some of these other things, so conversation training, exercise-based programs, devices, and group-based interventions. And we're going to talk about some of those today. The first one of those being exercise. So everybody wants it. Exercise is great in Parkinson's. I'm going to be the first person to wave the exercise flag. I know it's not always easy to do. I know it's challenging to start a new exercise program. I know it's challenging to keep up with an exercise program. But as with other aspects of Parkinson's disease, exercises for the speech changes that we have can be very effective. And this is just a schematic of how kind of speech in particular can be disrupted in Parkinson's. And it reminds us that there's changes not just in the tongue, but also in the lungs, changes in the voice box in terms of how the larynx and the vocal cords are used to produce the sound that becomes your voice and your speech. And so we need to treat at each one of those levels. And I'll talk to you a little bit about some of the exercise programs that do this. The one thing I do want to point out, though, is that the changes that we see in Parkinson's disease are not weakness. This isn't about muscle weakness or motor weakness. It's about what we call a reduction in scaling. That's a complicated kind of scaling. We weigh differently? No. What that means is that when your brain goes to select the appropriate response for speaking, be that enough volume or enough movement of the tongue or enough movement of the jaw, the brain picks the wrong solution. So if you think about all these as being basically kind of mathematical equations in the brain, and they kind of are, when that solution comes up, the brain picks the wrong solution. And the result is a voice that's too quiet without enough force to be heard for the particular situation that someone is in. The jaw doesn't open enough to make a particular speech sound. The voice box doesn't work well enough to produce a particular quality of voice. And so this is a problem over multiple aspects of Parkinson's disease, be that walking or choosing the correct word that you want to use, or processing the information that's giving you, or even producing speech. The brain is picking the wrong solution for the problem that is presented to it. And we call that a scaling problem. It becomes important because simple exercises like pushing your tongue out with resistance, or strengthening your jaw, or strengthening your facial muscles, even just strengthening the voice box in isolation and alone, do not work to improve the communication challenges in Parkinson's disease. They work for stroke because that's a disorder of muscle weakness. But they don't work in Parkinson's disease because this isn't per se a disorder of muscle weakness. So we need some different approaches. So, is that me? Okay. So one of the first exercises, I did wonder if I left my phone on, so one of the first exercise programs that we're going to go over is the Lee Silverman Voice Treatment Program. So who all knows about the Lee Silverman Voice Treatment Program in the room? A couple of people? Great. Who all has actually done the Lee Silverman Program? A couple of people. Excellent. So the Lee Silverman Voice Treatment Program is one option that we have for people with Parkinson's disease, and it addresses this issue of both the respiratory system, the laryngeal system, the mouth and the tongue and the jaw issue, and it addresses it not purely from a strengthening perspective, but from an increasing of the force of movement, this scaling problem that I talked about. So there's a series of exercises that are done with this program, very prescribed, very scripted. It's done the same way by every clinician who does this program. It's intense, and that you may be doing 60 to 70 to 80 repetitions of an exercise over the course of a 1-hour session. But that intensity is there with the intention of recalibrating the scaling problem in a way, to teach your brain how to respond, how to pick those solutions with a little bit more accuracy. It is the program that we've had around the longest. It's been around for about 20 years. I was actually trained in it as a graduate student right as I was finishing up. And the gains in terms of increased voice loudness seem to last for about 2 years. It also does improve swallowing as well. So there's a little bit of literature to show that it can help make swallowing better. The problem with LSVT is that many people out there feel like their perception is that it's the only solution that we have for people with Parkinson's disease and their speech problems, and it isn't. And it's a bit of a tough program because it requires going to therapy 4 days a week for 4 weeks. So it's an intense program, which doesn't suit everybody. right? Some people don't have the resources to get into a therapy program. It also only works when you do the exercises. You have to do them every day, and you have to continue to do them even after the treatment program is over, and that just doesn't work for some people with Parkinson's disease. So it's not the best solution for everyone. Even people who do the program and do it to its best ability sometimes don't get the same gain as others do. So it's not the right program for everyone, but it certainly is a good program for lots of people. So I'll play you a bit of a video.
Yes, I don't speak loud enough a lot of times. Anything else? Hoarse. Anything else? It's stuttering, which I never did before. Do this for me, if you would. Take a deep breath and say ah for as long as you can.
She probably sounds like some of your voices sound, right? Or the way your voice feels.
Does it cause you to talk less? Yes. Because I stutter and I can't be heard. If there's noise in the house, like when the kids come over, nobody pays attention to it because they can't hear me. So I get mad and then yell. Take a deep breath and say ah for as long as you can.
So that's 4 weeks later. That's 4 weeks after she's finished treatment.
Have you noticed changes in your speech or your voice as a result of the speech therapy? Oh, yes. What have you noticed? I talk louder. I think louder. I'm going to sing the some of the songs of my head one of these days.
So one of the things, and I'll just, before we change therapy, so that is an example of some of the changes, an ideal change that can happen with the Lee Silverman Voice Treatment Program. Does everyone get that outcome? No, they don't. And particularly for people with more advanced stages of the disease or people who have some mild cognitive changes or a little bit of dementia on top of their Parkinson's disease, I find this therapy particularly doesn't work as well for them. But I'm going to give you some other solutions for those cases here today. And so for me, I do that therapy, and I believe in that therapy, but I think it works for, again, some select cases. Overall, when people have compared the Lee Silverman Voice Treatment Program to other treatment programs, it neither works better than nor worse than. They really are all about equivalent. When I bring that up, because one of the challenges with getting access to this program is it requires being seen by someone who is actually an LSVT practitioner. Right, so it has to be someone who is certified in how to do the program. But again, there are adaptations. It can be done 2 days a week over the course of 8 weeks versus 4 days a week. So there's a little bit of flexibility in it. But that being said, at the end of the day, it is a very good program, and it does and can get the changes like you just heard. There's a new technology I'm going to share with you. So one of the challenges that we have in Parkinson's disease are also changes in swallowing. So does anyone in the room have some changes in their swallowing? Things don't go down always the right way. Yeah. Troubles in chewing, and this can happen for a variety of reasons as well as what affects speech or changes in the muscle strength. So we know that Parkinson's disease not only affects the muscles of the jaw and the tongue, but also has some effect on the respiratory or the breathing muscles. It's sometimes why people with Parkinson's feel out of breath when they're doing activity or feel like their voice gets tired. And so there's a device that's been designed by Christine Sapienza that is now available for purchase that works on building that respiratory support. And when she's talking about laryngeal closure there, it's the ability of the voice box to close tightly to protect the airway during swallowing. So this is a device that works on building expiratory muscle strength training, or how you use your breathing muscles for blowing air out, basically. So not taking air in, but pushing air out. It's a program, so these devices are available. They can be purchased from several companies now, not just from the university anymore. It's in online, so they have online instructions. You don't necessarily have to work with a speech pathologist to use this device, although I would suggest at least having a consultation with a speech pathologist first. So I make that caveat because they don't make it on their website, but I do think it's really valuable to work with someone, one, to make sure your voice changes are typical of Parkinson's disease and not something else, and to make sure that we don't need to be using any other therapies in adjunct with this. But it's basically a 4-week exercise program, 5 sets of exercises, 5 trials a day. It takes about 20 minutes to complete. And their outcomes are not bad in terms of improvements in swallowing in particular. So what they show is that when food and liquid tend to leak down toward the lungs of people with Parkinson's, making them cough or giving a tickle in their throat, that this helps with that closing off of that space and gets better airway protection. So this work isn't just in Parkinson's. They've looked at it in MS. People have been using these types of devices for a long time to build expiratory muscle strength. Athletes have been using them. So it's not new technology. It's just new in its application to Parkinson's disease. But there are a whole host, and I make sure I put this slide up, of contraindications. So if you have cardiac issues or chronic obstructive pulmonary disease, you probably shouldn't be using this device. So if you decide to go this route, and this is a device you think you might want to introduce into your therapy program, to make sure that you do work with a speech pathologist or minimum your physician in terms of taking it on. But it's a little device, and I've had a lot of physicians say, that can't possibly work. Well, no, actually, there's pretty good research to show it does work and works fairly well. So we're going to talk a little bit about some of the devices and technologies that are available because, as I said, exercise programs aren't for everyone. Some people just don't do well with the type of intense exercise programs such as Lee Silverman voice treatment. And the LSVT program still requires people to focus and think about their speech. You heard her say in that video, I have to think about being loud. And now I am loud and it feels good, but I think loud. And that's one of the mantras of the LSVT program, is to think loud, to think big. And not everyone can do that thinking loud and thinking big at the same time they're trying to do everything else in their life. More than that, with Parkinson's disease, you guys are focusing on a million things all the time. The timing of your medicine, how you take your first step, how you're walking, did you eat around your medicines correctly? Life becomes one big overregulated event, and for some people to add the added burden of thinking about their speech is just too much. So there's been a new device. This is my new tech. I'm not pushing any of these devices, so I'm not one large infomercial. It actually is to share with you the new technologies and the new hopes that are coming your way as people living with Parkinson's disease for some of these challenges. And there's a new device that actually will be available in Canada in the fall. I'm going to actually go down and visit Dr. Huber to get trained in how to do this, so I'll have access to it pretty quickly, hopefully as soon as I get done with this round of talks and can get down there. But this is a device that's based on the Lombard effect. So the Lombard effect is the natural tendency of your brain to make your voice louder when you're in a crowded room. So we've all had that experience. You go into a crowded room and your voice gets louder because you try to talk above the noise. That's an effect that's still preserved in Parkinson's disease. It's one of the strengths in Parkinson's disease that residual ability is still there. Your voice may not be as loud as someone who doesn't have Parkinson's disease, but the ability to raise your voice over that crowd noise is still there. So Jessica has designed a device. She's at Purdue University. She's been working on this for about 10 years now. That's called a Speech Vive. And the Speech Vive is a tiny device that works like a hearing aid. It doesn't occlude your ear, so you can still hear fine with it. What it does is sense the loudness of your voice, and when your voice gets too quiet, it plays a tiny little, what we call multi-talker babble noise, meaning that you have this little bit of crowd noise in your ear that you can't hear distinctly any of the words, so it's not distracting. But this multi-crowd noise, multi-talker noise, actually forces you instinctively to raise your voice volume without even thinking about it. So you don't have to think about being loud, your voice just becomes louder. And it's a little device that just fits over the ear.
This is what Scott sounds like without the device. And with the device.
When you speak, you get this crowd noise in your ear. It's rather like going into the mall
So that's literally with him having it on, that's immediately afterwards. So that's not a training piece, that's not an exercise piece. You put the device on and that's the kind of change that you get immediately. One of the challenges with people with Parkinson's and that scaling problem I was talking about is the fact that people with Parkinson's actually feel like their voice is loud enough. They're not raising their voice any louder because to them, they already feel like they're shouting. The amount of effort it takes to make their voice loud enough already feels as if they're shouting. And so what this device does is take some of that thought process away. They don't have to think about being louder. They don't have to feel like they're shouting because that effort almost just kicks in immediately. So for people for whom LSVT or some of the more structured exercise programs are not appropriate, this device may give us a few more hopes and options. This has been one of my favorite technologies in Parkinson's disease. I've been watching it for about 5 years, waiting for it to get FDA approval in the US, waiting for it to come to Canada, and it will be here in the fall. This device does require that you work with the speech-language pathologist to help with the settings and the programming and making sure that it's right for you, as well as worked into a bit of a therapy program with it. But I've been watching this one because of my own personal frustration that really when I do these exercise programs or LSVT, it only works for about half to 70% of folks. And I was looking for another option. So I've been watching this device very carefully and I'm quite excited to see it come here. So here's another video with it.
Great when you're left out of everything because you don't hear what's going on or what people are doing and where they're going and things like that. But I don't have too much of that anymore. And sometimes if I do and I haven't worn the device for a while, I'll have to get it out, put it back in, and just to remind you that this is what you have to do.
So I raised that, and I wanted you to hear that. One, I think she does the most brilliant job of anyone I've ever met at describing what actually happens to her as a person with Parkinson's trying to speak. And I watch that video every time and get a little teary-eyed. As many times as I've heard that from people living with Parkinson's, it always touches me when I think about the number of times we look over this problem, right? So I think I play it because I think she does a great job of doing that. But as well, what she says at the end is, when I don't wear the device for a while, my voice gets a bit quiet again, I have to put it back on. So one of the first questions I get from people about this device is, do I have to wear it all the time? And the answer to that may be no. So Jessica did a bit of a treatment program where she had people wear the device for 5 to 6 hours a day, and just in their normal activities, just their normal talking activities. And she wanted to see, would it make a long-term change in their speech to where they didn't have to wear it all the time? And indeed, it looks like it does. So this is a graph of some of her data. The black bars represent the amount of difference between the loudness of a voice for each one of these folks. Each bar is a subject. So the loudness of voice without the device on and the loudness of voice with the device on. And you can see for some people that increase was 4 to 8 decibels, so pretty substantial. And while some people did not improve, certainly about 75% did. And those were gains that were maintained even with the device off. So what this means is it may be a device that becomes not just an option for making voice louder and people who have trouble thinking about and focusing on their voice and doing these types of speech exercises, but it may also be a device that you don't have to wear all the time. So you can wear it, your voice gets recalibrated, you can go without it. If you notice your voice is getting quiet again, you put it back on and wear it a couple of days. So I'm really excited. You guys are the first well, outside of Ottawa, you guys are the first group of people living with Parkinson's disease to know about this device in Canada. So you're on the cutting edge now. Your physicians are going to tell you, no, that doesn't exist. You can say, yes, it does. But more importantly, start to talk to your speech pathologist about it. So we are advocating, and I'm one of the ones strongly advocating to have the ministry actually cover these devices as part of the ADP program. So just like they cover amplifiers, to be able to cover these devices for people with Parkinson's. And I think we're actually going to win that battle. So it may even be that we have some OHIP coverage for these devices. So voice amplification, or another technology or device that we often use, and I know voice amplifiers are the things that everybody hates, and I get it, and they're not everyone's favorite, but they are out there as potential options. This is a new type of voice amplification that we've been using of late, and it's something we borrow from the hearing world in terms of people who have hearing loss, and these are called FM systems. So it means that the person who's listening to you, that's this person here, simply just wears basically a necklace around their neck. It's incredibly lightweight. It's very, very lightweight. And the person with Parkinson's wears this device, a transmitter. It's completely wireless, so it's not a mic that's up by your face. If you have dyskinesias and lots of movement issues, it moves with you so that you don't have that issue of moving out of field of the microphone. They're lightweight. The sound quality is tremendous. And what it does is actually amplify your voice directly into the ear of the person that you're talking to. So this isn't one of those amplifiers where it feels like you're wearing a huge speaker and blasting out to everyone. You're directly amplifying to your conversation partner. You can have multiple of these. So at a dinner table, if you have 6 or 7 people over for dinner, they can all wear those. And they can set the amplification to what works for them. It's not around the face, so you can eat with it on, and it doesn't pick up a lot of the eating noise and whatnot. So this has become one of my new favorite ways, and it's something else that we're advocating for the ministry to start covering. The other thing it allows you to do is speak over distances. So people can be in different rooms. So someone can be in the kitchen, someone else can be in the living room, and you can still have the voice heard. So they are more expensive, certainly, than amplifiers. Presently, they're not covered by the ministry, but we're working toward that. But this creates a new option, and I have used it for folks who are still working so that they can make their voice heard in business meetings, when they're giving conferences, when they're teaching, when they're lecturing, or even within their office. So it is a solution that we're starting to build in as well, and one that you won't hear from many places. So this is a technology, or use of a technology that we kind of developed with some of our audiology colleagues in London. If you do need a voice amplifier, though, hold on to this slide, because this is a study that was done by one of our master's students at Western, where she actually looked at the quality of voice amplifiers and how people with Parkinson's actually liked them. So did any of you guys participate in that study with Dr. Adams and Monica? Did anybody come in? Sometimes I'll have some folks in. But what they basically did was actually create a list, and this is the rank ordering of which voice amplifiers work best from a satisfaction point of people with Parkinson's. And so if you do need a voice amplifier, this is something to kind of think about, because all of these are covered by the ministry except for the FM system. So finally, we're going to talk a little bit about some of the communication strategies, because it really does take a combination. Sometimes therapy is going to work, sometimes it's therapy plus voice amplification. It may now be this new Speech Vibe device that we can work into the mix. But at the end of the day, as I said earlier, we have to think about partners. We have to think about both the person with Parkinson's making some changes, and we have to think about their communication partner making some changes. And so I'll talk a little bit about some of those strategies. One of the first things that we talk about in communication strategies is making sure that we enhance skills that are still there, that we stay focused on the message, not just the accuracy always, but the actual message, and that we optimize strengths. And the first one I like to talk about is just optimizing the inputs and the outputs. What this means is that if you're constantly going, huh, every time your partner is talking, don't always assume it's the Parkinson's disease. It might always be your hearing. And those of you who've heard me give this, and I do travel with an audiometer at times. I started to bring it today. And those of you, we've done this little bit of experiment at some of our smaller groups where we had partners of people with Parkinson's have their hearing checked along with people with Parkinson's. You would be shocked at how many spouses, friends, partners actually have hearing losses that are substantial enough that are probably complicating this communication relationship. So the person with Parkinson's voice has gotten quieter, but you're also developing a hearing loss. Hearing loss is common. Anyone over the age of 60, you've got about a 30 to 40% chance of having a substantial hearing loss. And it takes very little change in hearing when you combine that with someone's voice who has Parkinson's disease to affect communication because of the types of speech sounds that are affected in Parkinson's. So next time you say, huh, just remember to maybe have your hearing looked at as well. It's also important to optimize lighting, so to make sure that you're sitting face-to-face with someone and that there's good lighting. Because people with Parkinson's, their voice can be a bit quieter. It's helpful to be able to both see their mouth and hear them. And so to make sure that you're sitting in a room that's well lit so that you can see their mouth to help with the message. It's important to minimize distractions, and any distraction in a room, particularly if folks are having trouble concentrating or taking in the conversation as well as putting together what they want to say. So that means if a message is really important, turn the television down, turn the radio down. Don't be washing dishes at the same time you're trying to have an important conversation. If you don't really care what someone's saying, that's fine. Keep washing the dishes and keep the television up and just do what we all do sometimes in cohabitating marital relationships. So that's going to naturally still happen. We're not saying that you have to change your normal patterns of communication. But if the message is important, like what do you want for dinner, or when is the next doctor's appointment, or even an important news event, or something's going on with the kids or the grandkids or the neighbor, turn those distractions down. Turn the television off for just a minute. Get face-to-face. Be about 6 feet apart or less. Make sure the lighting is good. And then have that conversation. Then you can turn everything else back up. So, but distractions can include grandkids. Distractions can include pets, right? So we often have this conversation with whole families to make sure they know how to reduce distractions. One of the strategies that we know works best in Parkinson's disease is simply to allow extra time. People with Parkinson's disease are remarkably accurate. It just takes them longer. And it's amazing how just a little bit of chatting with and talking to important people in someone's life about just giving more time to let someone respond, or doing what we call marking a place in the conversation. So if you know the conversation is going on at a relatively fast pace, you can watch your partner's face and say, John, we were just talking about this the other day, and I know you have really strong thoughts on this subject. Is there anything you want to add? And you give that time. Right? You've done two things with that. You've helped John understand what the topic of conversation is right at that moment. You've reorganized the focus of the conversation so that John can just focus on his response to that particular issue. And you've marked a place in the conversation where the conversation stops to allow John time to come into the conversation. It's one of the most powerful strategies that people with Parkinson's will describe is effective for them, and the partners will describe actually restore some of that social life. I recently did a training with a gentleman and his 3 Friday morning coffee buddies, because these guys had had coffee together for 20 years, and they weren't sure how to help their friend be able to get into the conversation more. And they had noticed over the course of the last 5 years, he had really withdrawn and was still attending the coffee group, but wasn't engaged in the conversation at all. So we did this training with them and took a video before and after, and the difference is huge. Now he's back engaged in the conversation. He gets his turn. Do they talk about as many things? No. But what they really wanted was to have their friend back engaged in the conversation, and we were able to help them accomplish that. If you're someone with Parkinson's and you need more time, then you need to let someone know. I have something I want to say, but give me a minute. It's going to take me just a minute. And you'll be surprised. While you may feel like you're inconveniencing people, you're not. What they typically want is to have you involved. They don't want you excluded from the conversation, and they're more than willing to help and support in that. Clarifying the message, so offering choices. This is a little bit more appropriate for people who have more substantial cognitive impairment in terms of the dementia with their Parkinson's disease, but always making sure, did I understand that correctly? One of the changes that can happen in Parkinson's disease is the trouble expressing emotions through facial expression, and also the challenges in processing other people's emotions. So with Parkinson's disease, it's not just this kind of masked faces that gives trouble expressing emotions, but particularly for negative emotions like sadness or worry, they can have trouble reading the facial expression and voice changes of others that indicate those emotions, and we know that from a whole host of research. So verifying that the message was understood. Did I understand you correctly? Were you making a joke? Was that sarcasm or humor? To make sure that you avoid any miscommunications in terms of, and those happen enough in our communication relationships, but to make sure. The other thing that becomes really important is using multiple modes of communication. So you say it, you write it down, you read it, you listen to it, any way that you can think of to reinforce messages. If I have one battle that I will face with doctors over and over again, it's this one. And I try to tell them, you know that all that stuff you just said, you know how much they got of it? About 2%. They're sitting there nodding their head, and this is true even for people without Parkinson's, right? I'm sitting there nodding my head, I think I've got it. But if you had them leave the room, and 30 minutes later you gave them a quiz on what the doctor just said to them, including medication changes, all of those things, the likelihood of how much they get correct is not very high. And we know that from a whole host of studies, and we know it's worse even in Parkinson's. So asking your physician to write things down or saying, can I have just a moment to write that down? Writing is affected in Parkinson's, we know that, but typing can be a little bit better. So maybe typing that in terms of using an iPad or asking the physician or the nurse to write it down for you. So don't think it's all your responsibility to get that information in. And doctors' visits are fast, and they're speaking quickly, and they're going 90 to nothing. It's not your fault. It's A-okay to say, slow down, I didn't get that. Can you tell me that again? I know you're busy. Would you mind writing that down so that if I get it home and I don't remember, I have something to refer to? It's A-okay. They just need that reminder to do it. So this is a little bit of what we've done, and we're almost done here in terms of how we put this multifaceted approach into place. So one of the things that I measure in people isn't just speech or isn't just how they're using language, but the number of breakdowns that they have in conversation. So they're having a conversation with a partner. It's how many times does someone go, huh, what, I didn't get that, or they give you this look. Or they jump onto another topic because they really didn't get anything that you said, but they don't want to tell you they didn't get what they said. Or they respond to you and you're sitting there going, wow, that was not at all what I meant, but you don't say anything either. So we call those conversation breakdowns, and you can measure them by the looks on people's faces and some of the verbal behaviors. So this was a study that we ran with a gentleman and his dad. The gentleman had Parkinson's disease. His dad was his communication partner. And what we did was look at, before we worked with them, almost half of their conversational turns ended up in breakdown. Half of them were just going nowhere. And both of them were just sitting there either walking away from the conversation or just engaged, but not necessarily talking to each other. So the first thing we did was put one of those FM systems in place, because the client with Parkinson's disease had been through all kinds of speech therapy. It just wasn't working for him. So we put an FM system on place so his dad could hear him better, because his dad did have a little bit of hearing loss. That took the conversation breakdowns down to about 30%. And when we did that conversation training, so went over those strategies that I was just talking to you about and really worked with them on how to use those strategies, it went down to 6%. So this multi-dimensional solution, this optimizing voice volume, consideration of hearing of the partner, as well as teaching of some of these strategies, as well as what this gentleman had already had in terms of some of his therapy, took us from 52% down to 6% in terms of those breakdowns. They were much happier, and they actually ended up taking a great trip in the car to Vancouver together, being able to hear and interact with each other the whole way. So it was a very good kind of outcome for them. These were their ratings of communication effectiveness. So both the mom and dad of this gentleman rated 72% beforehand. So this is how happy or satisfied they are with the conversation, and 93% afterwards. So kind of the take-home message here is, if the one-stop shopping hasn't worked for you, it's not your fault. If you did speech therapy and it didn't work for you, or you just couldn't stick with that exercise program, it's not your fault. It's our fault. We're expecting one solution to work for everyone, and it doesn't. And it really is about thinking creatively, both about the existing therapies and technologies that we have, the new technologies that we have coming down the pipeline, so that we as Canadians who are advocating for Parkinson's disease are ahead of the curve on this one, not behind, not following our U.S. neighbors, but actually getting ahead of them in terms of how we implement these into everyday clinical strategies. It's important to adapt over time. You may have done great with LSVT in the first 5 to 7 years of Parkinson's disease, but now that you've had it 15 or 20 years, man, it's just not giving you the same thing as it used to. So you go back for rebooster sessions, but it's just not working for you anymore. The medications aren't helping your speech anymore. So now let's think about some of these other solutions, such as communication training or amplification. So for me, I'm a huge advocate of saying that when a speech pathologist or a physical therapist or an occupational therapist gets involved with someone with Parkinson's, they need to be in it for the lifelong long haul. This isn't something we can just pop in and treat and jump out. It doesn't work that way. You've got to build those relationships and change the approach, change the strategy, pull different tools out at different places in time with the condition, not only for the person with Parkinson's, but for their entire family unit. So that's a bit of the message that we tried to kind of spread. Always involve partners. It doesn't have to be a spouse. It can be a best friend. It can be a golfing buddy. It can be a grandchild, so it doesn't have to be a partner, but make sure that there are partners involved in terms of implementing. So you recruit your partner. Who's going to be your therapy buddy? Who's going to be your conversation buddy to help this work for you, either in the situation to be the person who marks time and stops the conversation for you, or who helps you to do your exercises. And then always make sure it's meaningful. So this was kind of the talk today. I wanted to draw together for you some of this new technology. I hope to get you excited about the fact that there's more and more options coming down the road. And again, a reflection on my part to say 20 years ago, I couldn't give this talk. 20 years ago, we had one solution. 10 years ago, we had two. And now, with the greater interest in people wanting to help to improve the quality of life of people living with Parkinson's, I can actually give a lecture that says, or give a talk that says, we have a big toolbox full of things to select from. So it's about picking and choosing the one that works best for every individual. So thank you very much for having me today, and I'll take questions if you guys have any questions, so I'm happy to field those as well. So.
Any questions for Angela Roberts?
Your message is getting out to most of the neurologists that we all deal with.
Yep.
All these tools and.
Does it get out to them?
Yeah,
Man, I'm working really hard.
Okay.
I can speak to, and that's the first point that comes to me often from people living with Parkinson's and their family caregivers. It's that recognition when they go into their doctor's office that word retrieval is common, that slight changes in cognition are common, that there are other options that can be helped other than just the traditional LSVT or traditional swallowing approaches. So I'm trying, and certainly I do everything I can to I can speak to the London group, and most definitely, in terms of Mary Jenkins and Chris Hyson and Dr. Jog, I work closely with those folks, so for sure this message gets to them. And we're getting there. This is a growing profile in terms of, it gets approaching it from both issues. It's educating people with Parkinson's and their family caregivers to push and advocate for themselves. It's advocating from the side of speech-language pathologists to say, I'm confident providing different options now versus one option, because for years, speech-language pathologists would just say, I don't do LSVT, so I can't see people with Parkinson's, which is wrong, because we do have a lot of other options to offer. So it is a table that is turning. It is certainly a tide that is starting to turn. And again, really to the last, as I said, the thought that I would have had as many talks as I've had over the last month by those groups asking, if you'd asked me 10 years ago, I would have said it never happened. So I think we're getting there, and I appreciate that comment. We'll keep working toward that. So, any other questions? Yeah?
My question is, also work for the singing voice, or is it just for speech? The question was, does it work for
about the singing voice?
Or just for
yeah.
speech?
So one of the interesting things about singers, trained singers who get Parkinson's, is they tend to develop less voice changes because if you think about it as a muscle system that's already tuned in a way. Do the same differences that we see in the speech, effectiveness on speech, help with the singing voice? They are slightly different processes. It will help some, but it may not restore the pitch range to exactly what it was previously. So if you are a contralto or soprano, your pitch may still be lower. It will help some. But it's interesting if you're someone who uses your voice professionally or semi-professionally or even as a hobby in terms of a choir, it might be a combination of doing these strategies plus working with a voice coach, right, who can then take the strategies that you've developed from your speech therapy training. Will it automatically transfer some of it, but not all of it, because there are different motor activities. But if you combine that with working with a voice coach, it should help quite a bit. So the cost, yeah. So cost of the therapy vary, and I'm honestly incredibly embarrassed that I have to say that. A lot of the OHIP, so getting it through the hospital, is now gone because resources have been so slimmed down to the hospital speech-language pathologist. When I was first working in London, I could do it in the hospital outpatients, and it was free. That's not so much the case anymore. Some private practice speech-language pathologists will charge upwards of $1,500, which I think is wrong, and I will tell them it's wrong every day of the week, and I have no problem doing that. The other place to get it is through the university clinic at Western, because we do offer it through our clinic there at a reduced rate of $160, same therapy. So it means you're working with our students, but you're also working with the speech-language pathologist who's sitting right there helping to train the students, but that's a huge cost difference. But getting to London isn't easy for everyone, right? So each one of these do have a price tag with them, and it's one of the reasons why we're advocating quite strongly to get some ministry coverage for that. But it's an excellent point. Sometimes cost itself can just be prohibitive. For us in London, if even the $160 isn't something that you can work into your resources, because for some people it isn't, then we have a sliding scale fee, and sometimes we'll even not charge anything for it, depending on the individual. But again, it's part of our training program. Parkwood Hospital in London does a modified version of this as well that is covered underneath their general services. But it's not as accessible as it used to, which is the other reason why I kind of spread this message that, sure, it's the best therapy, it may be exactly what you want, it's not best for everyone, but that doesn't mean we don't have options if that's not available. But those are excellent questions. Yeah.
Okay, Angela, we have one question back here, and then maybe one more.
We have this gadget, which is one of the not recommended.
Yes.
How do I go about getting one that is recommended?
You know what? It's there. That's what we did in that study was actually trial all the commercially available voice amplifiers. And simply the people with Parkinson's who were in that study didn't rate that one, rated these others as being higher. So it doesn't mean it's not the right one. You know, it doesn't mean that these will certainly fit everybody. That one may work great. It just may be that enough people in the study didn't rate it as being what works for them, right? So, but every amplifier is slightly different, yeah.
Second part of my question, where do I go to get one of the FM?
Yeah, an FM
devices?
system, sure, an FM system. So, and again, this is spreading the message, right? So if you went to some of my audiology colleagues and said, I want an FM system to help with my wife's Parkinson's disease, they'd say, huh? So one of the places, because you guys are fairly close to us in London, yeah, so send me an email and I'll get you set up in our university clinic and they'll help you take a look at that. Because those are really again, my audiology colleagues, I think last year at the fall conference, one of my audiology colleagues spoke as in a way kind of advocating the other half of this work that he and I do together. And so I'll connect you with Dr. Scott and he'll be glad to do that or set you up with an audiologist who can. So absolutely. Just send me an email so I don't forget. Okay. Thanks, Mr. Richards. Yeah.
I have another voice question. I'm not a trained singer. I just like to sing in church, and I can't. And I just put it down to one of the many things that I can't do having Parkinson's. Do you have any suggestions? I don't know whether it's a breath thing, but I just can't sing anymore, and I used to be able to sing.
It could be in combination. I mean, one of the things that the Lee Silverman treatment will do, or speech therapy treatment can do, is not just increase loudness, but also increase range and teach you how to use that breath support a little bit better. So I would, again, suggest traditional speech therapy for you, or working with a voice coach with the goal of improving your singing voice. Sometimes that means just being able to turn it on when you want. It's in terms of keeping up with a particular song that is going on at a particular point in the music that you're singing. It's like your voice is there and then it's gone, and being able to turn it back on again. So it likely is a component of both the voice box system and the respiratory system for you. And so I think actually doing, again, an exercise program to help to build both of those would be good. Yeah. So thank you for your questions. And I think we said time-wise that was it, right? But if you have a question, if you want to write it down or pass that to me, I can answer those as well, okay?
Oh, they wanted to know what's your email. Can we get your email? She wanted to know your email.
Oh, email. Okay, hold on. Okay, everybody write this down. I'll go slow. It's A, as in my first name, South, S-O-U-T-H, my old last name. Things don't change fast. 4, the number 4. So it's A South 4, okay, at UWO. So University of Western Ontario, right? UWO.ca. So A South 4 at UWO.ca. And I answer emails from people with Parkinson's all the time. So feel free to send me your question and I'll send you back a response, okay?